Ventilator parameters are the settings and measurements used to control how a mechanical ventilator helps a patient breathe. Broadly, these parameters fall into two categories: the settings that the clinician sets called input parameters and the measurements the ventilator displays as it interacts with the patient called output parameters. The inputs directly signal the ventilator to deliver the breath. The output parameters reflecting the patient's response to ventilation helps assessing the effectiveness of ventilation and performing necessary adjustment. Tidal volume refers to the amount of air delivered to the lungs with each breath during mechanical ventilation. The recommended tidal volume range for most patients is typically between 6 to 8 milliliters per kilogram of ideal body weight. For example, if a patient has an ideal body weight of 70 kilograms, the tidal volume would fall within the range of 420 milliliters to 560 milliliters. In the case of acute respiratory distress syndrome where the lung compliance is reduced, a common recommendation is to use lower tidal volumes, generally between 4 to 6 milliliters per kg. Using lower tidal volume reduces the risk of lung overdistension and injury. The output parameter such as plateau pressure can guide tidal volume adjustments, with most clinicians aiming to keep plateau pressure below 30 centimeters of water. Tidal volume is also vital in the process of washing out carbon dioxide from the lungs. Adjusting the tidal volume directly influences minute ventilation, which is the total volume of air entering or leaving the lungs per minute and is calculated by this formula. An increase in tidal volume elevates minute ventilation, enhancing the removal of carbon dioxide from the bloodstream and thereby lowering PaCO2 levels. Conversely, reducing the tidal volume decreases minute ventilation, leading to CO2 retention and elevated PaCO2 levels. However, it is important to be cautious when adjusting tidal volume, as excessively high settings can result in ventilator-induced lung injury. Regular monitoring of blood gas levels is essential to ensure the appropriate balance between ventilation and lung protection. The approach to tidal volume setting varies between different modes of mechanical ventilation. In volume-controlled ventilation, the clinician sets the desired tidal volume, and the ventilator delivers this volume with each breath, adjusting the inspiratory pressure based on the patient's lung compliance and airway resistance. This mode ensures consistent tidal volume delivery, although the peak inspiratory pressures may fluctuate. In contrast, pressure-controlled ventilation allows the clinician to set the inspiratory pressure, and the ventilator delivers breaths at that pressure. The resulting tidal volume will depend on the patient's lung compliance and airway resistance, ensuring consistent inspiratory pressure but potentially varying tidal volumes with each breath. Fraction of inspired oxygen represents the percentage of oxygen in the air mixture delivered to the patient. Adjusting FiO₂ is crucial for ensuring adequate oxygenation, especially in patients with hypoxemia. Ventilators often start with an FiO₂ of 100% to rapidly achieve optimal oxygenation. Once the patient's oxygen levels stabilize, FiO₂ is gradually reduced to the lowest effective concentration to maintain adequate oxygen saturation. FiO₂ can be adjusted between 21%, equivalent to room air, and 100% depending on the patient's needs. The goal is to use the minimum FiO₂ necessary to achieve target oxygenation levels. Continuous assessment of arterial blood gases and oxygen saturation is essential to guide FiO₂ adjustments, ensuring sufficient oxygenation while avoiding hyperoxia. As the patient's respiratory status improves, FiO₂ should be titrated down to maintain adequate oxygenation with the least supplemental oxygen required. Respiratory rate is the number of breaths delivered by the ventilator per minute. For patients with normal lungs, such as those recovering from surgery or under sedation, a respiratory rate of 10 to 16 breaths per minute is typically sufficient to maintain normal gas exchange. Respiratory rate is a key factor in determining minute ventilation, which is the total volume of air moved in and out of the lung per minute. By regulating minute ventilation, it directly influences carbon dioxide clearance, and since carbon dioxide combines with water to form carbonic acid, its levels are crucial in maintaining blood pH. An increased respiratory rate enhances carbon dioxide elimination, shifting the equilibrium to the left. This reduces hydrogen ion concentration, raises blood pH, and leads to respiratory alkalosis. Conversely, a decreased respiratory rate causes carbon dioxide retention, increasing carbonic acid levels and resulting in respiratory acidosis. Respiratory rate also determines the timing of each breath, affecting inspiratory and expiratory durations. A higher respiratory rate shortens both inspiratory time and expiratory time, as total duration of each breath must fit within a shorter overall time frame. Reduced inspiratory time may limit lung filling and affect oxygenation in conditions like ARDS. A reduction in expiratory time can lead to incomplete exhalation and air trapping, particularly in conditions like COPD, where airway obstruction limits exhalation. In acute respiratory distress syndrome, the respiratory rate is set to optimize gas exchange while preventing ventilator-induced lung injury. A moderate to high respiratory rate, typically between 20 and 30 breaths per minute, is used as part of a lung protective ventilation strategy. This approach helps maintain adequate minute ventilation while compensating for the lower tidal volumes that are recommended to reduce lung injury caused by excessive pressure or volume. A higher respiratory rate is necessary to prevent the accumulation of carbon dioxide that results from the use of lower tidal volumes. The same strategy can be applied to other restrictive lung diseases, such as pulmonary edema and pulmonary fibrosis, where lung compliance is significantly reduced. However, it is important to be mindful of an excessively high respiratory rate, which can lead to breath stacking, increased dead space ventilation and respiratory alkalosis, as discussed earlier. The respiratory rate setting should be guided by arterial blood gas analysis and output parameters such as lung compliance and plateau pressure. The detailed discussion of these parameters is beyond the scope of this video. Obstructive lung diseases such as chronic obstructive pulmonary disease involve airflow limitation, making exhalation more difficult and increasing the risk of air trapping and dynamic hyperinflation. A lower respiratory rate in this scenario allows for a longer expiratory time, thus preventing air trapping. In addition, maintaining an appropriate inspiratory to expiratory ratio and monitoring for auto-PEEP are essential for effective management. In patients with metabolic acidosis, such as those experiencing diabetic ketoacidosis or lactic acidosis, the body's natural response is to increase ventilation to expel carbon dioxide and help normalize blood pH levels. This compensatory mechanism can be supported in mechanically ventilated patients by adjusting the ventilator settings to achieve a higher respiratory rate, typically ranging from 16 to 24 breaths per minute. This increase in respiratory rate enhances carbon dioxide elimination, thereby assisting in correcting the acid-base imbalance. It's important to closely monitor arterial blood gases to ensure that the ventilatory support is effectively managing the patient's acid-base status without causing respiratory alkalosis or other complications. The primary goal in managing a patient with traumatic brain injury is to prevent secondary brain injury from elevated intracranial pressure while ensuring adequate cerebral blood flow. Carbon dioxide plays a key role in this balance, as it is a potent cerebral vasodilator. Elevated levels increase cerebral blood volume and intracranial pressure, while lower levels induce vasoconstriction, reducing blood flow and decreasing pressure. The primary approach to managing intracranial pressure is to maintain normal carbon dioxide levels between 35 and 45 mm of mercury. Respiratory rate should be adjusted to ensure stable cerebral blood flow, preventing excessive vasodilation or vasoconstriction, both of which can negatively impact intracranial pressure. In cases of rapidly rising intracranial pressure requiring immediate intervention, mild hyperventilation can lower carbon dioxide levels to 30 to 35 mm of mercury. This induces cerebral vasoconstriction, temporarily reducing cerebral blood volume and intracranial pressure. However, this strategy should be used only for short periods, as excessive vasoconstriction can compromise brain perfusion and increase the risk of ischemic injury. Carbon dioxide levels above 45 mm of mercury must be avoided, as hypercapnia leads to cerebral vasodilation, increased cerebral blood volume, and worsening intracranial pressure. If hypercapnia occurs, increasing the respiratory rate can enhance carbon dioxide elimination. Regular arterial blood gas monitoring is essential to maintain an optimal balance between carbon dioxide clearance and cerebral perfusion. This table categorizes ventilation modes based on how respiratory rate is controlled or set by the clinician. In controlled modes such as volume-controlled ventilation and pressure-controlled ventilation, the ventilator fully determines the respiratory rate, with no patient effort required. In assist-controlled modes, such as assist-controlled volume control and synchronized intermittent mandatory ventilation, the ventilator ensures a minimum set respiratory rate but allows the patient to trigger additional breaths beyond the preset rate. From a clinical perspective, controlled and assist-controlled modes allow the clinician to set a mandatory respiratory rate, ensuring baseline ventilation. In spontaneous modes, including pressure support ventilation, the patient determines their own respiratory rate, while the ventilator assists in reducing the work of breathing. We will discuss ventilator mode in a separate video. Post-end-expiratory pressure or PEEP is the positive pressure that remains in the alveoli at the end of exhalation, keeping the lungs partially inflated and preventing alveolar collapse in mechanically ventilated patients. The waveform given here is the pressure time waveform. Looking at it, we can see that the pressure at the end inspiration is maximum when the alveoli is fully inflated. At the end of expiration, the pressure does not return to zero, meaning that the alveoli is not collapsed. If the pressure at the end of expiration somehow became zero, the lungs would fully collapse, leading to atelectasis and impaired oxygenation. A similar pattern is observed in the pressure-volume loop, where the curve does not return to zero, indicating the maintenance of lung volume. PEEP is known by different names in non-invasive ventilation. In BiPAP, a mode that delivers two pressure levels, it is referred to as expiratory positive airway pressure. BiPAP provides a higher inspiratory positive airway pressure to assist inhalation and a lower EPAP to keep the airways open during exhalation. Continuous positive airway pressure, on the other hand, delivers a single continuous steady pressure throughout the respiratory cycle. This constant pressure prevents airway collapse, functioning similarly to positive end-expiratory PEEP during exhalation. When we breathe normally, our lungs stay partially inflated at the end of exhalation because of functional residual capacity and the balance between lung elastic recoil and chest wall forces. The surfactant in the alveoli also reduce the surface tension because of water in the alveolar wall that tend to collapse them. However, during mechanical ventilation, this natural mechanism is lost, making PEEP essential. Firstly, by maintaining positive pressure at the end of exhalation, PEEP prevents alveolar collapse and preserves functional residual capacity, ensuring continuous gas exchange throughout the respiratory cycle. It also increases the surface area for gas exchange, improving oxygen transfer and reducing the need for high FiO₂, which can lead to oxygen toxicity. Additionally, PEEP protects against ventilator-induced lung injury from atalic trauma, a condition occurring from repeated collapsing and reopening of alveoli. This lung protective effect is particularly beneficial in ARDS, where the lungs are highly susceptible to injury. Moreover, PEEP counteracts absorption atelectasis, a condition where high FiO₂ replaces nitrogen in the alveoli, leading to collapse when oxygen rapidly diffuses out. Finally, PEEP reduces the work of breathing in spontaneously breathing patients on the ventilator. By keeping the alveoli open, it decreases respiratory muscle effort, benefiting conditions like COPD and ARDS. In one word, PEEP improves oxygenation. PEEP, while essential for improving oxygenation and preventing alveolar collapse, it comes with risks if not carefully managed. PEEP can cause auto-PEEP or intrinsic PEEP in patient with airway obstruction, such as those with asthma or COPD. In obstructive lung disease, airway narrowing creates resistance to airflow. When a ventilator delivers a breath, air enters the alveoli, but due to the obstruction, exhaled air takes longer to exit. Since the ventilator does not wait for full exhalation before delivering the next breath, not all the air leaves the lungs before the next breath begins. This results in air trapping where residual air remains in the alveoli, exerting pressure on the alveolar walls and distending them. With each successive breath, alveoli continue to expand, increasing the pressure inside them. This elevated alveolar pressure enhances lung recoil, which helps push some trapped air past the obstruction. Eventually, the amount of air exhaled in each breath matches the amount inhaled, preventing further lung expansion. This persistent, unintentional positive pressure in the alveoli is called auto-PEEP, and the resulting increase in lung volume is referred to as dynamic hyperinflation. The inability to fully exhale before the next breath is delivered is known as breath stacking, which can worsen hyperinflation, increase work of breathing, and lead to hemodynamic compromise if not carefully managed. In ventilator waveforms, such as the pressure time scalar, the pressure at the end of expiration does not return to the baseline set PEEP. This indicates that the lungs are becoming hyperinflated with high pressure due to auto-PEEP. In flow time waveform, the expiratory wave does not return to baseline, meaning that the inspiration has started before the end of expiration. The other problem PEEP can cause is a drop in cardiac output. Venous return to the heart is very dependent on the difference in pressure between that in the thoracic cavity where the heart is enclosed and that in the circulatory system. In normal breathing, the respiratory system operates as a negative pressure system. When we inhale, the diaphragm moves downward, expanding the chest cavity and creating a drop in intrathoracic pressure. This negative pressure pulls air into the lungs and also reduces pressure on the right side of the heart, making it easier for blood to return from the veins. When PEEP is applied, it maintains positive pressure in the lungs at the end of exhalation. This causes a rise in intrathoracic pressure, which reduces the pressure difference between the veins and the right side of the heart, leading to decreased venous return. Since less blood reaches the heart, the amount it pumps out cardiac output is also reduced. In patients with pulmonary hypertension or right heart dysfunction, the right ventricle already struggles to pump blood into the lungs due to increased pulmonary vascular resistance. High PEEP further raises intrathoracic pressure, which compresses pulmonary blood vessels and increases pulmonary vascular resistance. As a result, the right ventricle has to work harder to push blood forward, leading to increased right ventricular afterload. This added strain can worsen right heart failure, making it more difficult for the heart to effectively circulate blood. Excessive PEEP can have several pulmonary complications including barotrauma, volutrauma, impaired carbon dioxide clearance, and ventilation perfusion mismatch. High PEEP can cause overdistension of the alveoli, leading to increased pressure within the lungs. This elevated pressure can result in air leaks, where air escapes into areas outside the lung tissue. The potential consequences include pneumothorax, where air leaks into the pleural space and causes lung collapse, pneumomediastinum where air collects in the mediastinum, and subcutaneous emphysema where air escapes under the skin, often appearing around the neck and chest. It can also lead to volutrauma, which occurs when alveoli are overstretched due to high PEEP causing damage to the lung tissue. This overstretching triggers inflammation, increases capillary permeability and allows fluid to leak into the lungs, potentially resulting in pulmonary edema. High PEEP can impair carbon dioxide clearance by reducing the efficiency of air movement in and out of the lungs. This occurs because high PEEP keeps the lungs partially inflated at the end of exhalation, leading to several effects. First, it can reduce lung compliance, making the lungs stiffer and harder to expand during inspiration, which results in shallower breaths. Second, it can decrease tidal volume, reducing the amount of air exchanged with each breath and limiting carbon dioxide removal. Lastly, it can cause air trapping, where incomplete exhalation leads to the accumulation of carbon dioxide in the lungs. As a result, carbon dioxide builds up in the bloodstream, leading to ventilatory failure. The lungs rely on a balance between ventilation and perfusion to ensure efficient gas exchange. This balance is called ventilation-perfusion matching. When excessive PEEP is applied, it can lead to overdistension of well-ventilated alveoli. This means that the alveoli expand too much, putting pressure on the surrounding pulmonary capillaries. As a result, these capillaries become compressed, reducing blood flow to those areas. Since these alveoli are still receiving plenty of air but less blood is flowing through them, the balance between ventilation and perfusion is disrupted. This VQ mismatch means that some areas of the lung are well ventilated but underperfused, reducing oxygen exchange efficiency. Just like increased intrathoracic pressure reduces venous return to the heart, PEEP can also affect venous outflow from the brain, leading to increased intracranial pressure. When PEEP elevates intrathoracic pressure, it compresses the jugular veins, which are responsible for draining blood from the brain. This compression impairs venous outflow, causing blood to accumulate in the cranial circulation. In patients with traumatic brain injury or stroke, this reduced venous drainage can worsen cerebral edema and increase ICP. Now that we have explored both the benefits and drawbacks of PEEP, the key question is, how much PEEP is ideal? There is no universally agreed upon method for determining the optimal PEEP level. Various approaches, including oxygenation-based strategies, compliance-guided methods, and pressure volume curve analysis, have been proposed. However, the ideal PEEP setting remains patient-specific, requiring a balance between lung recruitment, avoidance of overdistension, and hemodynamic stability. The ARDS-NET sliding scale for PEEP adjusts levels based on FiO₂ requirements to optimize oxygenation while minimizing lung injury. This approach adjusts PEEP in response to the patient's oxygenation needs, increasing PEEP when FiO₂ requirements are higher and lowering it when FiO₂ is reduced. As we can see, ARDS-NET provides two tables. The upper one with lower PEEP higher FiO₂ and the other with higher PEEP lower FiO₂. Lower PEEP higher FiO₂ table is typically used for hemodynamically unstable patients or those at risk of barotrauma as it applies lower airway pressures. Higher PEEP lower FiO₂ table is preferred for patients with severe ARDS or significant atelectasis as it promotes alveolar recruitment and reduces oxygen toxicity. A recruitment maneuver causes transient, sustained increase in transpulmonary pressure designed to open up collapsed, airless alveoli. Several methods for recruitment maneuvers have been described to determine optimal PEEP, with the sustained pressure method described by ARDS-NET being the most widely used. In the method described by Arnold et al., a recruitment maneuver involves applying 40 cm water of pressure for 30 seconds to recruit alveoli. This is done using pressure-controlled ventilation, where the ventilator is set to pressure control mode, the respiratory rate is set to 0 to prevent spontaneous breaths during the maneuver, and the inspiratory pressure is increased to 40 cm water and maintained for 30 seconds. After the maneuver, PEEP is adjusted stepwise, for example, from 25 cm water, while monitoring oxygenation, lung compliance, and adverse effects to determine the optimal level that maintains alveolar recruitment safely. Pressure volume loop can be used to set optimal PEEP using various methods. Let's talk about inflection point, which is one of the method. The first method is using the lower inflection point, which is the pressure at which lung compliance suddenly improves during inflation. Below this point, the lungs are stiff due to collapsed alveoli. At this point, many alveoli begin to open, making lung expansion easier and improving compliance. This point represents the minimum pressure required to initiate effective alveolar recruitment. To set PEEP, it is typically positioned just above the upper inflection point to keep alveoli open throughout the breathing cycle, including expiration. If PEEP is set too low or below this inflection point, it can cause repeated alveolar collapse and reopening, leading to atelectrauma. Conversely, setting PEEP too high above this point can result in overdistension of already open alveoli, increasing the risk of barotrauma. The other method is the identification of the upper inflation point of the deflection or expiratory limb. Deflection limb in a pressure volume loop represents exhalation phase, where lung volume decreases as air is expelled. The upper inflection point on this limb marks the pressure below which alveolar collapse begins. So, setting PEEP above this point helps prevent decrepitment and maintain lung volume. There are other methods described to identify optimal PEEP, but it's beyond the scope of this video. PEEP settings should be tailored to each patient's specific needs and response to therapy. The benefits of PEEP must be carefully balanced against its potential drawbacks on the pulmonary, cardiovascular, and neurological systems. For normal patients undergoing surgery, PEEP of 5 cm water is usually used to mimic the physiological PEEP of normal spontaneous breathing. In obese patients, excessive chest wall weight reduces lung compliance and increases the tendency for alveolar collapse. So, higher PEEP is beneficial in these patients to maintain alveolar recruitment and counteract the increased intra-abdominal pressure. Studies suggest that PEEP more than 10 centimeters water may be necessary to prevent atelectasis and optimize ventilation in obese patients. For ARDS, ARDS-NET's ventilation strategy remains a pragmatic approach to setting PEEP in most mechanically ventilated patients. Patients with obstructive airway disease are prone to air trapping and dynamic hyperinflation. High PEEP may worsen air trapping and increase the risk of intrinsic PEEP or auto-PEEP. To minimize this, external PEEP should be set lower than the measured auto-PEEP. If a patient is on controlled ventilation such as being paralyzed or deeply sedated, PEEP can be set as low as possible as these patients do not need help overcoming auto-PEEP for triggering. We can even not apply PEEP, in which case PEEP is referred to as zero end-expiratory pressure or ZEEP. If the patient is triggering breaths, external PEEP at 50 to 70% of the measured auto-PEEP can be applied to reduce work of breathing without worsening hyperinflation. In such a case, extrinsic PEEP elevates the baseline pressure and reduces pressure needed to trigger the breath. Pause the video and try to understand how PEEP help reduce the inspiratory pressure required to trigger breath. Additional strategies like increasing expiratory time by reducing the respiratory rate can allow more complete exhalation. Bronchodilators can be used to decrease airway resistance, facilitating easier exhalation. PEEP can increase intrathoracic pressure, which may impede cerebral venous outflow, potentially leading to elevated ICP. Conversely, in certain conditions, PEEP has been observed to decrease ICP, particularly in hypovolemic states. PEEP enhances oxygenation, reducing hypoxic cerebral vasodilation, which can lower cerebral blood volume and subsequently decrease ICP. A study indicated that PEEP levels up to 12 cm water result in negligible increases in ICP, suggesting that moderate PEEP may be safely applied in patients with acute brain injury. However, continuously monitoring of ICP and cerebral perfusion pressure is necessary when adjusting PEEP levels to detect and address any adverse changes promptly. In mechanical ventilation, a respiratory cycle refers to one complete cycle of breathing delivered by the ventilator, consisting of inspiratory and expiratory phases. Let's illustrate this one: a pressure time waveform. During the inspiration phase, the ventilator delivers a set volume or pressure of air into the lungs. In the expiration phase, the lungs passively release the air as the ventilator stops delivering pressure, allowing exhalation. The phases can be appreciated on other waveform and loops too. Some ventilators also include a brief pause phase between inspiration and expiration, known as the inspiratory hold, which helps assess lung mechanics such as compliance and plateau pressure. The time of a respiratory cycle refers to the total duration of one complete breath, including both inspiration and expiration. It is determined by the respiratory rate and expressed as the total cycle time. For example, if the respiratory rate is 12 breaths per minute, the total cycle time would be 5 seconds per breath. This total cycle time is divided into inspiratory time and expiratory time. Inspiratory time is the duration of the inspiratory phase and expiratory time is the time left for passive exhalation after inspiration. The ratio of inspiratory time to expiratory time is called I/E ratio and is commonly set at 1:2 or 1:3 to allow sufficient time for exhalation. Using the same example with a total cycle time of 5 seconds and an I/E ratio of 1:3, the inspiratory time is 1.25 seconds, and the expiratory time is 3.75 seconds. Depending on the mode of ventilation, Inspiratory time is set through various methods, though respiratory rate determines the overall breath cycle time. Let's start with volume control mode. Volume-controlled ventilation is a mode of mechanical ventilation in which the ventilator delivers a preset constant tidal volume to the patient during each breath. Since the ventilator delivers a fixed tidal volume, the inspiratory time depends on how fast or slow that volume is delivered by a certain amount of flow rate. To quantify the relationship between flow rate, tidal volume and inspiratory time, we use this formula. Flow rate is the speed at which the ventilator delivers the air into the lungs. When the flow rate is increased, the ventilator delivers the tidal volume more quickly, which means that the inspiratory phase is shorter. In contrast, when the flow rate is decreased, the ventilator delivers the same tidal volume more slowly, increasing the I time. As an example, for a tidal volume of 0.5 liters at a flow rate of 60 liters per min, the inspiratory time is 0.5 seconds, while at a flow rate of 30 liters per min, the I time increases to 1 second. Tidal volume is the total volume of air delivered during inspiration. While the tidal volume is set, its impact on I time comes into play indirectly when adjusting the flow rate. Larger tidal volumes require more time to deliver if the flow rate remains constant. For example, a tidal volume of 0.7 liters at 30 liters per minute results in an inspiratory time of 1.4 seconds, while a tidal volume of 0.3 liters at 30 liters per minute results in an inspiratory time of 0.6 seconds. In volume-controlled ventilation, we typically don't set the I/E ratio directly. Instead, the I/E ratio is determined indirectly by adjusting tidal volume, flow rate and respiratory rate. Since I time is determined by tidal volume and flow rate, the expiratory time is calculated based on the total cycle time. Thus, while volume control ventilation does not allow direct I/E ratio setting, you can adjust flow rate, tidal volume or respiratory rate to achieve the desired ratio. Some modern ventilators may display the I/E ratio as a guide when adjusting these settings. Pressure control ventilation is a mode of mechanical ventilation where the ventilator delivers breaths at a set pressure. The main goal is to ensure that the pressure remains constant during the inspiratory phase of each breath regardless of the volume of air delivered. To achieve this, the ventilator adjusts the flow of air to reach the set pressure. The clinician sets the pressure that will be delivered as well as the inspiratory time. Flow rate and tidal volume is not used to determine inspiratory time because it is not constant and will lead to inconsistent inspiratory time. The respiratory rate is also set, but it doesn't directly control the inspiratory time as it is set by the clinician. The expiratory time, however, is completely dependent on respiratory rate. As we have seen, respiratory rate determines the total cycle time and thus influences the expiratory time. If the total cycle time is low, expiratory time also reduces as inspiratory time is fixed by clinicians. Thus, I/E ratio in pressure control ventilation is determined by inspiratory time and respiratory rate. Here is a big table of how inspiratory time, expiratory time and I/E ratio is determined in other modes of ventilation. If we understand volume control and pressure control ventilation, we can directly determine I time, E time, and the I/E ratio in other modes since they follow the same fundamental principles. In any mode with mandatory breaths, such as assist control volume control, assist control pressure control, and synchronized intermittent mandatory ventilation, these parameters are set similarly, either indirectly through flow rate and tidal volume in volume control-based modes or directly through inspiratory time in pressure control-based modes. The main difference comes from patient-triggered breaths, which can alter the overall respiratory rate. In spontaneous modes like pressure support ventilation there are no set mandatory breaths, so inspiratory time and expiratory time are entirely dependent on the patient's effort, making the inspiratory to expiratory ratio variable. Setting appropriate inspiratory time, expiratory time and inspiratory to expiratory ratio need adjustment based on the patient's specific respiratory conditions. Longer inspiratory allows for a more complete filling of the lungs, enhancing oxygenation, while adequate expiratory time ensures complete exhalation, facilitating the removal of carbon dioxide from the lungs. The I/E ratio is strongly influenced by inspiratory time but must be adjusted to ensure adequate expiratory time. Let's look at how to set them in ARDS. In ARDS, where hypoxemia is a major concern, the goal is to enhance alveolar recruitment while minimizing ventilator-induced lung injury. Prolonging inspiratory time in ARDS enhances lung recruitment by allowing more time for alveoli to fill with air. A longer inspiratory time also increases mean airway pressure, which is the average pressure applied to the airways throughout the respiratory cycle. The increased mean airway pressure improves oxygenation by keeping alveoli open longer. Lastly, increasing inspiratory time reduces peak inspiratory pressure, reducing the risk of barotrauma. Due to the increased inspiratory time, expiratory time is shortened to maintain the respiratory cycle. With shortened expiratory time, incomplete exhalation can lead to breath stacking and dynamic hyperinflation. Reducing respiratory rate in such cases can increase total cycle time, allowing more time for exhalation. Continuous monitoring of flow waveforms, auto PEEP levels and end-tidal CO2 helps detect inadequate exhalation and the need for further adjustments. In ARDS, the I/E ratio is often set to 1:1, deviating away from the normal ratio of 1:2 or 3. An inverse ratio like 2:1 is also used to improve oxygenation in severe hypoxemia. However, an inverse I/E ratio means that expiration is significantly shortened, increasing the risk of breath stacking, dynamic hyperinflation, and auto PEEP. In obstructive lung diseases, the goal is to allow sufficient expiratory flow to counteract increased airway resistance. This ensures effective carbon dioxide elimination and prevents air trapping and dynamic hyperinflation. Inspiratory time is shortened to allow for prolonged expiration, while expiratory time is extended to facilitate full exhalation. The I/E ratio is typically set between 1:3 and 1:5 to accommodate slow expiratory flow in cases of severe airway obstruction. However, shorter inspiratory times may reduce tidal volume, requiring adjustments to the ventilation mode or settings to maintain adequate minute ventilation. A ventilator's flow rate or inspiratory flow rate is the rate at which gas is delivered to the lungs during inhalation. It gives us a measure of how quickly or slowly gas like oxygen is delivered to a patient's lungs. For a normal spontaneously breathing patient at rest, the typical inspiratory flow rate is around 20 to 30 liters per minute. Most adult patients receiving mechanical ventilation, the inspiratory flow rate is typically set around 60 liters per minute, but can be adjusted higher or lower based on the patient's individual needs and clinical presentation. Flow rate and tidal volume are closely related because flow rate determines how quickly tidal volume is delivered during inspiration, while both flow rate and inspiratory time together determine the total amount of air that enters the lungs per breath. If flow rate increases, tidal volume can be delivered faster with shorter inspiratory time. If flow rate decreases, tidal volume is delivered slower, leading to a longer inspiratory time. Suppose a ventilator has a flow rate of 60 liters per minute and an inspiratory time of 1 second. Since 60 liters per minute equals 1 liter per second, the tidal volume delivered would be 1 liter. If the inspiratory time is increased to 1.5 seconds, the tidal volume would be 1.5 liters. In a real clinical scenario, this calculation is only practical in volume-controlled ventilation, where the ventilator delivers a set tidal volume and adjusts the flow rate to meet the inspiratory time, whereas in pressure-controlled ventilation, tidal volume depends on lung compliance and airway resistance. However, this relationship provides important information about how changes in flow rate or inspiratory time impact tidal volume. Flow rate plays a crucial role in determining how gas is delivered to the lungs during mechanical ventilation. Ventilators can deliver gas in different flow waveforms, which is represented on ventilator as flow time waveform. Different types of flow time waveforms are associated with various modes of ventilation and patient conditions. When the flow is directed into the lungs during inspiration, it is plotted as a positive value on the waveform because the flow is moving in the direction of the ventilator towards the patient. When the patient exhales, the flow reverses direction, moving out of the lungs and away from the ventilator. This reversed flow is plotted as a negative value because it represents movement in the opposite direction. We will concentrate on the inspiratory part here, as the expiratory flow is usually passive and same for all the different types of waveform with gradual decline to zero before the next breath. The square flow waveform is characteristic of volume-controlled ventilation, where the ventilator delivers a preset volume of air to the patient at a consistent, unchanging rate throughout the inspiratory phase. This constant flow rate is represented by a flat, horizontal line on the flow time waveform, indicating that air is being delivered steadily into the lungs. At the end of inspiration, when the ventilator stops delivering air, the flow rate suddenly drops to zero, which is shown by a sharp, vertical drop in the waveform. This abrupt change marks the transition from the inspiratory phase to the expiratory phase. This consistent flow ensures the full tidal volume is delivered but can increase peak airway pressures, especially in patients with stiff lungs. The descending or decelerating flow waveform seen in pressure-controlled ventilation and some volume modes starts with a high flow rate that gradually decreases during inspiration. This flow pattern improves gas distribution and reduces peak pressures. The accelerating or ascending flow waveform starts with a low flow rate that increases throughout inspiration. It is less common but may be used in specialized situations where an increasing flow rate is beneficial. The sine wave flow waveform gradually increases to a peak and then decreases smoothly, closely mimicking natural breathing and making it more comfortable for patients. It is used particularly during spontaneous breathing or pressure support ventilation. Finally, the exponential decay flow pattern seen in pressure-controlled ventilation starts with a high flow rate that gradually decreases as the lungs fill. This pattern, shown as a downward-sloping curve on the waveform, helps distribute air more evenly and reduces peak airway pressures, making it gentler on the lungs. It's same like descending pattern, except that the flow decline is descending ramp is linear at the same rate, whereas in exponential decay, the flow decline is gradual, giving it a curved appearance. Setting the appropriate flow rate depends on the ventilation mode, patient condition, and clinical goals. First, let's look at how we set flow rate on volume control ventilation mode. Flow rate can be set manually in volume-controlled ventilation as a fixed value, or it can be adjusted indirectly by setting tidal volume and inspiratory time, which the ventilator uses to calculate the required flow. In both methods, understanding the relationship between flow rate, tidal volume and inspiratory time is important. For example, if the tidal volume is 500 milliliters and the inspiratory time is 1 second, the required flow rate would be 30 liters per minute. If the inspiratory time is shortened to 0.8 seconds, the flow rate must be increased to 37.5 liters per minute to maintain the set tidal volume. So, if we set the I time, the ventilator automatically adjusts the flow rate to deliver the set tidal volume within that time. And if we set the flow rate directly, the inspiratory time is determined based on the time required to deliver the tidal volume. Some ventilators also allow the selection of flow patterns, such as square or decelerating flow. Note that the flow rate calculated from this formula is very low, whereas even normal spontaneous breathing typically requires higher flow rates, especially in decelerating flow patterns. A resting patient may need at least 40 to 60 liters per minute of inspiratory flow, which is considerably higher than the values seen in a volume-controlled, square-wave pattern. Instead of relying solely on this calculation, ventilator settings should consider inspiratory flow demand, compliance, and resistance. However, the method does provide insight into how tidal volume, inspiratory time, and flow rate are interconnected in mechanical ventilation. In pressure control ventilation, flow is not set directly. Instead, inspiratory pressure is used to set inspiratory flow to achieve the desired tidal volume. The relationship between flow rate and tidal volume is explained by this simple equation. Increasing the inspiratory pressure increases the pressure gradient between the ventilator and the lungs, leading to a higher flow. Conversely, lowering inspiratory pressure reduces the pressure gradient, resulting in lower inspiratory flow. The tidal volume also increases too, but depends on lung compliance. The flow pattern in pressure-controlled ventilation is decelerating. This is because flow is driven by the pressure gradient between the ventilator and the lungs. At the start of inspiration, when the pressure difference is greatest, flow is at its peak. As the lungs fill and alveolar pressure rises, the pressure gradient decreases, leading to a progressive decline in inspiratory flow. In pressure support ventilation, the patient triggers the breath by generating a small negative pressure. This triggers the ventilator to deliver a preset constant pressure during inspiration. The goal is to support the patient's spontaneous breathing by providing additional pressure. When the patient tries to inhale more deeply or forcefully, their inspiratory demand increases. This causes the ventilator to increase the flow rate to match the patient's increased effort and maintain the set pressure. When the patient's inspiratory effort slows, the ventilator will decrease the flow rate to maintain the same pressure. So in pressure support ventilation, the flow rate depends on the set pressure support level and adjusts dynamically in real time based on the patient's inspiratory effort. The flow during pressure support follows a decelerating pattern just like the pressure-controlled ventilation, with high pressure at the start of inspiration with gradual decline as the inspiration continues. Now let's look at the effect of setting flow rate too low or too high. A low flow rate can lead to a prolonged inspiratory time, which may reduce expiratory time and increase the risk of breath stacking or auto-PEEP. It can also cause air hunger and ventilator desynchrony if the patient's inspiratory effort exceeds the delivered flow. As the ventilator fails to meet the patient's demand, they struggle to draw in enough volume, increasing respiratory effort. This mismatch may lead to additional breath attempts leading to dyssynchrony, increased work of breathing, and discomfort. A high flow rate on the other hand can cause the ventilator to deliver air quickly into the lungs. This rapid flow causes a higher volume of air to be pushed into the lungs in a shorter time, which raises airway pressures. Elevated PEEP increases the risk of barotrauma. High flow rates may also shorten the inspiratory time, potentially leading to inadequate alveolar ventilation and compromised gas exchange.